Hello. Good evening, students. Can you hear me? Can you see me? Yes, there'll be a slight lag from where we are streaming. Are we live? Yes, can you hear me? Yes, you can see me. Yes, fabulous. Okay, so welcome all of you to this session. And yes, welcome all of you. Can all of you see me? Can all of you hear me? Am I visible to all? Audible to all? Yes. Okay. So welcome all of you to this class. I'm Dr. Punit Bhojani and we are here to discuss some important MCQs for the upcoming NEET PG examination in the subject of OBGY. Okay, just before we proceed further, this is the PAS subscription where you get everything. You get the daily live classes, the structured courses. I'm a part of many of them. Of course, live tests would be there and unlimited access would be there. Okay, so this is the iconic subscription which you get the best of both the worlds as per your requirement, which is your live classes, the video revision lectures, quizzes and rapid revision courses. Also couple of announcements. These are for you daily free test on Unacademy platform where you can have 20 questions in 20 minutes. So it's like a 2020 season going on. Okay, so I can see, I'm not able to see the chats. One second. Yeah. Okay, yeah, and similarly, so you can attend this test every day and at the NEET PG at 8 o'clock, and if your target is FMG examination at 8:30, INI CET 9 p.m. so this is the test available for all of you to attempt and give. And this is an announcement that a free grand test for NEET PG 2021 200 MCQs. The new pattern is there on 7th, 14th, 21st, 28th of March. So every week you can give one grand test before your preparation for the 18th April examination. I've also made one more video where you can go and see the list of important topics. That video should also be out now on YouTube soon, when I've given the entire list of important topics for OBGYN have been given by me, and you can see that video where I also discuss what is the likely pattern for the questions, and also very important how the paper distribution will be, and what to expect in OBGY. And this is the last mile or last chance. This is the batch starting from 1st March to 31st March, where I will be starting the OBG from the 17th of March, and in March ending itself we will be finishing off the entire OBGY along with me. All the best of the country will be there. MENTOR, mentor. Do not forget, mentor is the code to get the 10% off or the discount. So you can start with this subscription, and it's the last chance to crack before the NEET PG. I will be covering the entire OBGY rapid revision, almost 18 hours, and all the 20 to 25 MCQs in OBGY in the upcoming NEET paper will be from these videos only. That is what we would like to give you. Okay, live classes, in-depth preparation, test, doubt clearing session and approach. Okay, mentor is the code. So depending on this, you can download the Unacademy app and start cracking, and depending on your requirement, if your target exam is the next year, then you can go for the 1-year subscription, or now even a 3-month, 6-month subscription. MENTOR, mentor is the code to crack the exam to get the discount, and do not forget to apply this code to get the discounts. Okay, and with this we now start with our MCQ discussion for the day, and we have some questions. Some will be confusing, some will be straightforward, and the pattern would be like hopefully these questions would be coming in your NEET PG. This is my best of judgment. We have created this. So first MCQ for the day, and all of you can also participate and give in the chat box, which of the following is not used as an emergency contraceptive? Not used as an emergency contraceptive. Okay, which of the following is not? We've got 4 options: LNG, ulipristal, IUCD or misoprostol. Is anybody with the answer? Right, wrong does not matter. All of you please try to participate. So all of you know that the emergency contraception, yes, anybody? Anybody with the answer? So the emergency contraception are also called as interceptives. By the way, why I have chosen this subject? Because contraception, one topic, one MCQ comes for sure. Okay. Yes, Alpana Sahu, Amit Dhama, very good, all of you. Yes, will be coming to in very good. So emergency contraceptives also called as interceptives. What is the meaning of interceptives? That mainly they act by making the uterus unsuitable for implantation. The uterus will not be suitable for implantation. That is how they work. They are the interceptives. Interceptives means prevent implantation. That is again a very important MCQ. Okay. Yes, all of you. Okay, very good. Many of you are correct. Okay, so emergency contraceptives, they are given when if there is an unplanned, unprotected intercourse. Boyfriend, girlfriend meet, they have no plan of having sex, but they'll end up having sex. That's one. So unprotected intercourse. Second is you have used a condom, लेकिन sex के बाद पता चलता है अरे condom में तो hole था, मतलब condom ruptures or tears during intercourse. And third is if a rape victim comes to you, then we are supposed to offer her emergency contraception immediately. And main action, I told you, prevents implantation. Now there are two types of emergency contraception. One is the hormonal and second is the mechanical. Okay, and in hormonal, which ones do we have? And mechanical is IUCD. Any of the intrauterine contraceptive device can also act as an emergency contraception. And in hormonal one, OC pills were used in the past, not so much popularly used, but just to keep it as your MCQ purpose, you can remember it. And the two main is your LNG and ulipristal. Both of them MCQs are expected, so we know this. I'll come back to this about LNG and ulipristal. Some more important points I'll be telling you in some time regarding both these things. And IUCD also acts. And what is the emergency window also we'll discuss in all that time. So the answer over here, yes sir, LNG acts as emergency contraception, ulipristal acts as emergency contraception, IUCD yes. Answer is misoprostol. Please understand, anybody, where do I use misoprostol for? Because it is all which are the following. No, is not. Okay, so misoprostol sir is used for MTP, medical termination of pregnancy, is what I use misoprostol for. And that is not emergency contraception. When the contraception fails and patient land up with pregnancy, then I might have to go for MTP. So misoprostol also can. Anybody, any other use of misoprostol? Can you tell me? Misoprostol has got a few more uses which you should know. There is also one of the drugs available for management of postpartum hemorrhage, and misoprostol also can be used for IOL, standard short from induction of labor. Okay, but MTP is the one of the main uses of. Yes, very good Amit Dhama, is also for PPH. Very good. So MTP के लिए main use करते हैं misoprostol, and that is not emergency contraception. Okay, now this LNG IUCD can be inserted up to 5 days. Okay, so emergency window is up to 5 days following sexual intercourse. The mechanical IUCD can be inserted. It's very important, because can anybody tell me when does the implantation take place? Sir, implantation takes place on the 6th day following fertilization. On the 6th day the implantation will take place. So even if up to 5 days we are going to insert a IUCD, it will work. Okay, now for my hormonal ones, two main, as I told you, LNG and ulipristal, both are tablets. LNG, anybody with a dose, it is 1.5 milligram single tablet or a single dose. And very popular, the brand name iPill. iPill is the brand name. We may not want to know the brand name, but iPill is very popular, so we should know what does iPill contain. So iPill is nothing but a single tablet of 1.5 milligram. Doses could be asked to you in the upcoming exam. Effective within 72 hours. Okay, within 72 hours of unprotected intercourse, unplanned intercourse, we can give the patient the LNG tablet. And very new is now ulipristal. Anybody tell me ulipristal is what kind of a drug? So ulipristal is a drug which is SPRM. Anybody, what is SPRM? Anybody? Yes, what does the ulipristal is? Sir, selective progesterone receptor modulator. Yes or no? Ulipristal is SPRM, selective progesterone receptor modulator is what is ulipristal. And the advantage is that this is now also available for emergency contraception. Dose very likely to be asked in the upcoming exam, 30 milligram single dose. I repeat, yes, very good, 30 milligram single dose is the dose of ulipristal for emergency contraception, and this is up to 5 days. Okay, just now launched in India. Okay, and that is up to 5 days. In fact, the brand name is also up to 5. So ulipristal, by the way, ulipristal is also used for fibroid. That is a separate story, a separate discussion altogether. But ulipristal is a sperm selective progesterone receptor modulator, and it can be used up to 5 days following sexual exposure. You're getting 2 days extra. This is 3 days. This is 72 hours. This is 3 days with IPIL or LNG, and here I am getting up to 2 days extra, so up to totally 5 days following the act of unprotected intercourse. Patient can take the ulipristal tablet single dose. Okay, so now we know very clearly, yes sir, LNG 1.5 milligram single dose, ulipristal 30 milligram single dose, IUCD can also be inserted, misoprostol is for MTP. Moving on to the next question for your benefit. Yes, anybody, can anybody, but Amit Dhamma, the dose for fibroid will be 5. Okay, fibroid dose is a separate discussion. I'll just discuss because you asked me. Fibroid ke liye what we give ulipristal is a 5 milligram tablet or a 10 milligram tablet. Okay Amit, and but it will not cure in one, so it is generally for 2 to 3 months daily. Okay, 2 to 3 months it will take, because when I give for fibroid, I want long term action. It will not, one tablet will not shrink the fibroid. It's medical management of fibroid. Generally 5 milligram is preferred to be taken daily. Okay, so do not get confused. For emergency contraception is just one single dose. Okay, it's just one single dose, 30 mg, but 5 milligram is the dose for fibroid daily, to be used for at least 2 to 3 months. Okay, yes, moving on, very very important, can anybody tell me the diagnosis? I have got a patient who has come to us for treatment of hirsutism. She is obese. Okay, a clue given to you, acne is there, hirsutism is there, irregular periods. So very very simple, straightforward diagnosis. These are all the clinical case based scenarios expected in the upcoming exam. Yes, anybody with the diagnosis? Yes, yes, yes. And what has been told to us? LH is 24, FSH 8. Okay, so if you see what is the FSH to LH ratio, yes, yes, it is 8 divided by 24, 1 is to 3 is the ratio. Okay, simple mathematics. And which of the following is the most appropriate treatment for her condition? Yes, anybody? ABCD. So this is a patient which is having PCOS as your diagnosis from the history. Okay, why from the history? Because you can see point number one, because in PCOS, polycystic ovarian syndrome, there would be an ovulation. Patient would not be ovulating properly, so that an ovulation will give rise to irregular periods. In my actual classes we have explained to you why an ovulation leads to irregular periods and secondary amenorrhea. Patients would not be getting menses properly. Okay, so that is an ovulation. And PCOS is excessive testosterone also, so that is, so this an ovulation is responsible for a secondary amenorrhea, irregular periods, and of course then infertility also, because if you are not producing egg, you will be infertile. But that's the management of infertility. An increase in testosterone will give rise to acne, oily skin, hirsutism. Okay, A and H are my short form for acne and hirsutism. Okay, so we have got, and of course there, all of you know, the main thing is there would be insulin resistance. Insulin resistance is also one of the reasons why the patient develops PCOS, and obesity plays a role over here. It's a vicious cycle. Obesity leads to insulin resistance leads to more obesity. Okay, so obesity, majority of the patients of PCOS are also obese. We have got lean PCOS also, but still majority patients, 80% would be obese. So that is a crystal clear thing, all of you, that yes sir, there is obesity question mein hai, acne, hirsutism hai, irregular periods hai. So all the clinical features points to PCOS. And also the normal, anybody, this is FSH to LH ratio in this condition is 1:3 given as per the question 8 and 24. Anybody? Normally the FSH to LH ratio is 2:1, and in PCOS the ratio becomes ulta, 1:2 or even 1:3 or even 1:4. Why? Because LH is going to increase, it's going to be persistently elevated LH, so LH will be on the higher side, which is also the case over here. Look at our LH is 24, FSH is 8. Okay, so the ratio is 1:3. So all pointers towards the PCOS. And by the way, they have not said sonography, but all of you very famous. If I do ultrasonography, what is expected in this patient? Anybody? If I do ultrasonography, we are likely to see necklace of pearl pattern. So I'm not only discussing this MCQ, all the other MCQs around this topic, you will be likely to see multiple small follicles arranged in the periphery, necklace of pearl pattern. Now somebody is saying option A, somebody is saying option C. Okay, now please understand one thing, that metformin is there in all the options given to you. Very good. Why should metformin be given? Anybody? Metformin I will definitely give to the patient because she is obese. Anybody? What does metformin do? Sir, metformin is our insulin sensitizer. Metformin is a insulin sensitizer, and definitely I would like to give it to a patient who is having PCOS, and specifically if she is obese. Metformin will help the patients to lose weight. Metformin will tackle the problem of insulin resistance. Metformin also helps in suppression of androgen, and but also lifestyle modification. Patient has to be told to do weight loss also. So metformin, yes, would be helping. Now I have got, yes, of course, very good, Amit. Weight loss also should be told to the patient. So weight loss is there. Now here please understand this, that the options which are available, option number, please pay careful attention, that the letrozole and clomiphene are for ovulation induction. So that is not the case over here. Please understand one thing, metformin and letrozole would be given to the patient only if she is infertile, because that we should know, that sir, why is there infertility? Because of an ovulation. So when a patient of PCOD comes to me with infertility, that is the time when the patient comes to infertility, that is the time that I would like to go for ovulation induction medicines. Yes or no? When there is infertility, that's not the case over here. Clearly our patient is 20-year-old girl and she has come to us with treatment of hirsutism and acne and irregular periods. So the best treatment for the infertile patients is ovulation induction. But when you have got other problems like your acne, hirsutism and irregular periods, very good all of you, the treatment is OC pills. Okay, the treatment is OC pills. And one of the things which I like to tell all the patients or all the students is that naam mein hi answer hai. According to me, they are made for each other. Okay, that all the problem of PCOS can be beautifully symptomatically controlled by taking OC pills. Okay, naam mein hi answer hai, PCO ulta kar do OC pe. Okay, PCO OC pe, ठोको ताली, clap if you feel happy. Okay, so all the problems of PCOS can beautifully controlled by taking OC pills. Okay, so OC pills will help in acne, hirsutism as well as irregular periods. Okay, and here, so now we know, sir, option number 2 is out, option number 4 is out. Now between A and C, what is to be chosen? And I will prefer to go with cyproteron. Why cyproteron would be preferred? Because sir, cyproteron is a progesterone with a anti-androgenic property. Okay, so please pay attention that sir, in PCOS I would like something, so that is the answer over here, because I would like her to be on cyproteron, because cyproteron is a anti-androgenic property. So all of you please pay attention that yes sir, any OC pills can be given, but one with a cyproteron is preferred. In fact, LNG is very high level MCQ, that LNG should be avoided. So yes, only a simple MCQ will be only OC pills. Okay, please understand, simple MCQ will only be OC pill, and OC pill is also correct. But when I have to choose, okay, so only OC pill is also, if the MCQ is there, that's okay. But when I have to choose the progesterone component, we prefer to give which one? We prefer to go with the one which is having a cyproteron containing OC pill. Why? Because cyproteron is a progesterone with a anti-androgenic property, and that is what I require over here, because the patient of PCOS is androgen excess. Yes or no? Cyproteron is a anti-androgenic property. Okay, anti-androgenic property, and that is what I want, because you can see over here that the testosterone is on the higher side. So to tackle this problem of acne and hirsutism, I require something which is anti-androgen. And in fact, LNG will slightly worsen the acne, so LNG should be avoided, because LNG will slightly cause increase in acne and hirsutism. It's a very high level stuff, because our LNG can worsen the problem. So the best answer over here is option number C, ocipil with cyproterone along with metformin should be given to the patient. Very very important clinical diagnosis, please make it and then choose the best. And lastly, one very important take home message: please do not interchange the treatment. That is not acceptable. That means, what am I saying is that when the patient comes to you with infertility, at that time please don't give her ocipils. पेशेंट बोलेगा ये डॉक्टर पागल है, मुझे बेबीज चाहिए, आई वांट बेबीज एंड डॉक्टर इज गिविंग मी बर्थ कंट्रोल पिल्स. ओके, how will she conceive? So when the patient has got infertility, that time you have to go for ovulation induction, letrozole, clomiphene, all that you have to give. Okay, that time I have to go for letrozole and clomiphene citrate. You have to go for ovulation induction. And similarly, when a young girl comes to you, unmarried girl comes to you with acne, oily skin, irregular periods, that time don't make her ovulate, because that is, you are wasting the patient's egg. You don't need to make her ovulate. So there is no need to make her ovulate. That time I will give her ocipil as a symptomatic approach, and preferably with her cyproterone. Okay, one more very very important clinical case based scenario I am showing you. First, all of you type in the chat box the diagnosis. Okay, we have got a 20-year-old patient. Okay, moving on. So that is all about PCOS, very important MCQ likely to be coming in the exam. Okay, we have got a 20-year-old patient again coming to us with emergency ward with 2 months of amenorrhea, so early pregnancy with pain, with shock. So anybody shocked in early pregnancy? Why shock? BP 90/60, hemoglobin 6 gram. Okay, urine test positive. So anybody, what is your diagnosis? Yes. Okay, this is your not only ectopic pregnancy, very good, it is ruptured ectopic pregnancy. Why? Because the dictum what you will remember is shock in early pregnancy. Okay, underline the word early. The important word is early. See, late in pregnancy, patient can go in shock even because of eclampsia or APH or PPH, but shock in early pregnancy is because of ruptured ectopic, unless proven otherwise. What is the meaning of this is unless proven otherwise? What is the meaning is that when I have a patient who comes to us with shock and in early pregnancy, okay, then first it is always ruptured ectopic, unless proven otherwise means what? That's sir, first I will think of ectopic. First think of only ectopic pregnancy and also ruptured ectopic. Okay, unless you approve it otherwise. Okay, means unless you get it that there is something else definitely, then otherwise always first think of ruptured ectopic. Now 2 MCQs back to back, please pay attention how they will fool you in the exam. Anybody with the answer to this MCQ, please type in the chat box, all of you. I'm not giving the answer, I have only given the diagnosis. 20-year-old girl with 2 months amenorrhea, 90/60. Next immediate line of treatment is, anybody with the answer? Will I go for laparotomy, cross-match bloods, IV fluids, medical management, laparoscopy? Anybody? 30 seconds for all of you to answer. Okay, anybody? 20-year-old, 2 months pregnancy is there. Why 2 months amenorrhea is there? Okay, and pain in abdomen is there, and shock is there, and urine test is positive. So she is pregnancy and shock and a severe shock, and the next, so ruptured ectopic is our diagnosis. So like this, as I told you, clinical MCQs will be coming in the exam. Next immediate line of treatment is, okay, somebody saying 1, somebody saying 2, fair enough. Okay, so I'm not giving the answer yet, okay. Now the next MCQ. Array sir, you have given the same MCQ by mistake. No, it is not mistake. Please see, the options have now changed and also the questions have changed. Yes, again I have got a 20-year-old patient. If I am the examiner, back to back I will give both the MCQs in the exam. just to see whether student has understood the concept or not. Again pain in abdomen, again shock, again BP 90 same, urine test positive. So again, yes sir, this is also ruptured ectopic, but the MCQ best treatment for this patient is, now anybody with the answer, best treatment. Okay, so any idea what is the difference between the two MCQs? That should be clear to all of you. I will discuss both the MCQs back to back. Here the question was next immediately what will I do? I will give the answer, and here the best treatment is. So all this is to fool the students, to confuse the poor students to what will I do. So now here the best treatment is, anybody best treatment, somebody is saying laparotomy on option 3 no. Okay, so now let us discuss one by one. Point number 1, shock in early pregnancy is ruptured ectopic unless proven otherwise, that all of you know. So when immediately the patient, please understand one thing, there are two things when the patient comes to you with ruptured ectopic. Okay, when the patient comes to you with ruptured ectopic, two things. Okay, ruptured ectopic, then one is the general management and next is the specific management. Okay, so general management is what I will do immediately first. What is that? Sir, put in 2 wide bore IV lines, yes or no? 2 wide bore IV lines, collect blood for cross match. Okay, collect the patient blood sample for cross match, yes or no? Then start immediately IV fluids, immediately first crystalloids, colloids, and then even order for blood, and even blood transfusion may be started. That is what I do immediately, yes or no? Please understand, this is the general management of any shock, whether it is a question in medicine, surgery, or like a road traffic accident or gynac, or any shock for that matter, which could be your APH, PPH, all this part will remain the same. 2 wide bore IV lines, fatafat, IV fluids, collect blood for cross match, and even order the blood, and if possible start the blood also. Okay, so the next immediate line for this is cross match and IV fluids, yes or no? Which is the answer to this? Very important. And that is what you do. Go back to your ward, go back to the labor ward. If you get a patient of this in your emergency, you will be, that is what you will be doing first as interns के फटाफट वो बोलेंगे चलो फटाफट ABC airway breathing circulation, put in IV line, collect the blood, send blood for cross match, and immediately start IV fluids, crystalloids and colloids, yes or no? So that is the next immediate line of treatment. Please understand this. And yes, I know, and here in a patient of shock, laparoscopy is out of question. Medical management is only for the stable patient, and the lapro, this cross match and IV fluids is immediately followed by laparotomy. So 2 followed by 1. I agree with all of you, but 2 is the answer. Laparotomy is the definitive treatment for this patient. Okay, so please read the question like this, is just to confuse the student. Next immediately what will I do, and the best treatment or the definitive treatment. Okay, so 2 followed by 1, but here the answer is 2. Sir, I will immediately go for collect the blood for cross match. Blood and IV fluids has to be done first, even before you proceed for laparotomy. Okay, and laparotomy is the best treatment or the definitive treatment. Okay, the definitive treatment, what would be it? So the specific treatment is, yes, exploratory laparotomy. And anybody, what do I do in laparotomy? Anybody? Please understand, it's a ruptured ectopic. The tube is bursted and the whole tube is bleeding. So salpingectomy is the gold standard surgery. Salpingectomy, underline boldly, is the gold standard surgery. Okay, what is the meaning of salpingectomy? You are cutting off patient's one tube, but don't feel sad. Another tube is enough to cause population explosion. Matlab one tube is there. You don't feel sad that, oh, I'm cutting off patient's one tube. Okay, because that tube is torn, the third. So you cannot conserve the tube. Okay, so here I will not go for cross match and IV fluid because that's not the best or the definitive treatment. That's not the answer. Again, laparoscopy out in shock, and laparotomy and salpingectomy is the answer to this MCQ. All of you, is this understood to all of you? What is this salpingostomy? I will tell you in 2 minutes. Okay, and why it cannot be done in ruptured ectopic. Okay, so salpingectomy is the gold standard for ruptured ectopic. When the patient comes to you with ruptured ectopic, immediately the specific treatment is exploratory laparotomy with salpingectomy as the gold standard surgery. What do you do? There is no time to waste. Immediately what we are supposed to do is like Okay, immediately what we do is we just enter the abdomen. Okay, just see, okay, one tube would be normal, uterus would be there, this tube will be torn and tethered, and there'll be bleeding, bleeding, bleeding. Immediately just go and apply a clamp and get the clamp. Okay, and only when you clamp this, the whole bleeding will stop. Okay, so clamp it immediately, tie a knot, remove this tube and come out. Okay, and remember the dictum, quick in quick out, मतलब time pass नहीं करना है, quick in quick out. Whatever blood is there in the pelvis, that all you suck out and get the tube out. Okay, so remember this, salpingectomy is always the gold standard surgery for a ruptured ectopic. Is understood to all of you? Now what is this salpingostomy? Okay, salpingostomy and salpingotomy, please understand one thing, that those are mainly done, that suppose please understand one thing, suppose I have got a unruptured ectopic pregnancy. I have got a unruptured ectopic pregnancy, and as a desperate method to save the tube. But please understand that is rarely done, because when I save the fallopian tube, I am increasing the risk of again ectopic pregnancy on the same side. Yes or no? Why? Because why did the ectopic take place? Because sir, the tube was defective. So by keeping the defective tube in the body, I am increasing the risk of again ectopic on the same side. But suppose I do this, so this is mainly only theoretically, practically never done. What I do is, all of you please pay attention, that either I will cut open the fallopian tube, I cut open the fallopian tube. Okay, we cut open the fallopian tube, and I will remove this ectopic pregnancy out, and then I suture the tube back. That is called as salpingotomy. And suppose I do not even suture this tube and I keep it open, I just remove the ectopic pregnancy out and I keep the fallopian tube open and allow it to heal it by secondary intention, that is called as salpingostomy. So all this is not preferred nowadays, because there is increased risk of ectopic pregnancy. Getting the tube out, salpingectomy is the gold standard surgery. Is this understood to all of you? So do not go for salpingostomy. And by the way, that is also only in cases of a unruptured ectopic. Here the whole tube is, it's like a mini bomb blast, the whole tube is torn and tethered. Is this understood to all of you? So salpingectomy is always preferred for the patient, and that is the answer. Yes or no? Laparoscopy is not possible in shock. Okay, laparoscopy is not possible in shock. So I quickly repeat what is the difference. Let's say the next immediate line of treatment is IV fluids and cross match, and the best treatment is laparotomy and salpingectomy. Yes or no? Thumbs up if all of you have understood this. The last part will get quickly time for last MCQ, the Asherman syndrome. Anybody? What is Asherman syndrome? Anybody? Sir, Asherman syndrome is presence of intrauterine adhesions. We get it because of excessive curettage or repeated curetages. Asherman syndrome is nothing but intrauterine adhesions. And what will it cause? Anybody with the answer? What is Asherman syndrome going to cause? Yes, perfectly correct. Will there be polymenorrhagia? No. Will there be amenorrhea followed by menorrhagia? No. Will there be happen followed by? No. The answer is this. Okay, that why what will happen is that, sir, because of this fibrosis and adhesions, the patient will say that the menses is becoming less. Okay, the menses of the patient will keep on becoming less. So that is going to give rise to a scanty menses. Okay, because as the fibrosis will happen, the patients, because the endometrium is getting replaced by fibrous bands, fibrosis is happening, so the menses become scanty. Okay, so patient will also say, sir, doctor, typically I had bleeding first for 3 days, 5 days, then only 3 days, then only 1 day, then hardly any bleeding or spotting. Okay, for only for few hours. So bleeding keeps on becoming scanty, which is my hypomenorrhea. And when the entire uterine cavity is obliterated by fibrosis and adhesions, there would be amenorrhea, and that would be secondary amenorrhea. So as the condition of Asherman will worsen, the hypomenorrhea, which is scanty menses, is followed by amenorrhea. This is secondary amenorrhea. Obviously, I don't get polymenorrhea first followed by oligo, neither do I get amenorrhea followed by menorrhagia. This amenorrhea followed by menorrhagia, we get it in patients of DUB, and in patients of menorrhagia, of metropathia hemorrhagica, we get such condition where because of anovulation there is amenorrhea, and then there is menorrhagia. Okay, so this is your typical example of your HPO axis imbalance. You get this kind of a presentation. So here for Asherman syndrome, which is intrauterine adhesions, the answer is scanty menses followed by secondary amenorrhea. And all of you know, anybody, what is the best way to treat Asherman syndrome? Best way to treat Asherman syndrome, anybody, is not only doing adhesiolysis. I will go and do hysteroscopy adhesiolysis. Okay, hysteroscopic adhesiolysis should be done for the patient. That means I will go through the hysteroscopy route, and through the hysteroscopy route I'll try to see I can break all these adhesions, and I will try to make the cavity normal. Okay, so hysteroscopic adhesiolysis is the best treatment for the patient with Asherman syndrome. Yes or no? Yes or no? Yes. Okay, so I hope all of you had a great time today. Thank you for coming in today. Do not forget to use this code MENTOR to get your subscription. Join as soon as possible. This batch is starting from 17th March, where if you come, I'll make you experts in 18 hours of gynecology. I'm going to give your entire, I'll try to cover almost everything. MENTOR is the code to get the Unacademy app, and use this code. Depending on your requirement, 3 months, 6 months, 12 months subscription can be taken with the mentor code MENTOR to get the discounts. Okay, as per your requirement. And the, as I told you, the last mile batch, also the target next 2022 batch is also starting. Will also be the part, and many other batches, upcoming batches would be there. This last mile batch, very important, last chance for you to crack the PG examination. Along with me, all the top educators will be there, which you can give you all the best knowledge for your examination. Free grand test series also, all of you please attend on these days. And as I said, don't worry, the exam will be simpler. It will not be very difficult. It will be as per the standard examination every year what happens. And I wish you best of luck for all the upcoming exams. Thank you very much. Bye bye, best of luck, and thank you for coming in today. Thank you very much. Bye bye.